critical issues in the management of APD and gastroesophageal reflux disease. My talk will cover acid peptic disorders, starting from history, prevalence, risk factor, signs, symptoms, complication, and treatment. So the most important thing in medicine is the history. If you take a good history, you will reach a diagnosis most of the time without any investigation. So case 1 is 50 years old male having burning sensation in the epigastrium. He complains of some heartburn after almost every meal. There's no change in his bowel habit. He has been taking over-counter drugs and testers like with some relief, and he reports mild intermittent epigastric pain. Endoscopy revealed multiple erosions in the lower part of esophagus. Biopsy, no H. pylori detected. Diagnosis of gastroesophageal reflux disease was made. Our second case, 50 years old female having this much deformities, और ये deformity for a medical student मेरी mom PG से कि ये spot diagnosis of rheumatoid arthritis है, having pain epigastrium for last 3 months, burning in collectors, non-radiating, aggravated by meal and relief with empty stomach. Patient is taking NSAIDs, steroids for rheumatoid, smokes 10 cigarettes a day and drinks socially. GP suggested ranitidine, has not helped, presented with hematemesis 4 episodes in last 24 hours. And patient was in shock on arrival. On endoscopy, you can see there is a large ulcer in the peripyloric region of stomach. Further endoscopy revealed another ulcer in the proximal part of duodenum. So what is Gerd? As you can see, gastroesophageal reflux disease, as per ACG, a chronic relapsing condition resulting from exposure of distal esophagus to reflux gastric content, often chronic and relapsing in nature. As far as epidemiology of Gerd in Asia, prevalence of Gerd in Eastern Asia ranging from 2.5% to 6.7% for at least weekly symptom of heartburn or acid regurg, and may be increasing. Up to 40% of general US population report symptom of Gerd, around 10 to 20% having daily symptoms. And prevalence of Gerd in Pakistan, 24% of our population is suffering from Gerd. And 71% of the patient, they give history of spicy meal or spicy Friday food as a major cause. Study carried out in Aga Khan showed that 74% occurrence of symptom postprandially and 32% patient only consulted physician, 32% self-medication, and around 32-33% patient consulted physician. So large population don't seek health care advice. You can see 67% of the people. What are the risk factors that you will ask in history? As you can see in previous 2 cases, we have seen that one patient was taking NSAIDs and steroids. So there are some dietary factors that may aggravate Gerd symptom. Remember, they don't cause Gerd, but they aggravate the symptom, like citrus fruit, carbonated drink, caffeine, heavy meal, food, fatty food, spicy food, and alcohol. Though there is a weak evidence, but what our practice shows, that once patient is having these symptoms, then once patient is having the GERD, then these elements definitely aggravate the symptoms. Though there is weak evidence that lifestyle factor aggravate GERD symptoms, for example, obesity, but severity of esophagitis correlate with weight once BMI is more than 30. Though there are studies that contradict that weight loss indicate no effect or improvement in GERD. Similarly, smoking, lower esophageal sphincter pressure and with acid neutralization effect of saliva and physical activity, running might provoke GERD by increasing the pressure. Then there are certain medications. There are few medications that impair the lower esophageal sphincter tone or function, like beta agonist, like theophylline, like anticholinergic, like tricyclic antidepressant, like progesterone, alpha-adrenergic antagonist, diazepam, calcium channel blockers. And then there are drugs that directly damage the esophageal mucosa, like acetyl salicylic acid or other NSAIDs, tetracycline, quinidines, and bisphosphonates. And what is peptic ulcer? As you know, ulcer is a break in the mucosa that extends in the peptic through the mucosa with a fibrous base and inflammatory cells. You can see ulcer. Then there are factors that reduce the mucosal resistance, lead to formation of ulcer. For example, H. pylori infection, NSAIDs, aspirin, smoking, and reflux of bile. Difference between duodenal and gastric ulcer, if you see, the incidence of duodenal ulcer is 4 to 5 times more common than the gastric ulcer. Ulcers are more common in first part of duodenum, more on interior wall, and as far as stomach is concerned, they are more on lesser curvature of stomach. Duration may be acute or chronic in case of tissue, and in gastric ulcer, usually they are chronic. Malignancy is quite rare in duodenal ulcer, but quite common in gastric ulcer, may be benign or malignant. Both are more common in elderly population, though duodenal ulcer are more common in middle age, starting from 30 to 55 years of age, and gastric ulcer in 55 to 70 years of age. Onset usually duodenal ulcer, symptom relieved after taking meal. And यहाँ पे थोड़ा सा उल्टा लिखा गया है. So relieving factor is food in duodenal ulcer. So gastric ulcer is aggravated by taking food. So you can see here another ulcer in the prepyloric region. There is a visible blood vessel that is a danger sign and sign of bleed. You can see ulcer in the tissue, large on interior wall in the first part of duodenum. Similarly, when you come to GERD, there are two main categories. If you see the 100 patient, 60% will have endoscopic negative reflux disease, and 40% will have signs of esophagitis on endoscopy, and among these, 35 will have no complication, but 5% will have complications. And once these patients are reviewed on high resolution endoscopy, that shows minimal changes to the structure of esophageal mucosa. Patients with GERD have similar pattern with or without esophagitis, like 100% patient have heartburn, epigastric pain, regurg, belching, nausea, bloating, abdominal distension. Cough may be caused by acid reflux entering the lung or stimulating the vagus nerve. Gerd may be associated with unexplained chest pain. There are complications of peptic ulcer disease like perforation, like hemorrhage, gastric outlet obstruction. You can see this lower picture. This is old way of treatment of GI bleed. Then there are alarm symptoms. You must be extra careful. Like if patient is having anemia, anorexia, swallowing difficulty, I mean to say dysphagia, or recent onset of progressive symptoms, GI bleed, whether hematemesis or melena, progressive unintentional weight loss, persistent vomiting, epigastric mass, or any patient more than 55 years old and having recent onset dyspepsia. Multiple ulcer leading to peptic stricture formation. You can see there is stricture formation need dilatation. Esophageal stricture resulting of healing of erosive, like corrosive intake के बाद ये इस तरह की picture आती है. फिर we need to give bougies के साथ हमें multiple dilatation procedures करने पड़ते हैं. Complication of GERD is mainly Barrett esophagus resulting from acid damage lining of esophagus and causes chronic esophagitis. Damaged area heals in a metaplastic process and abnormal columnar cell replace squamous cell in the esophagus. And ultimately, you can see the specialized intestinal metaplasia can progress to dysplasia and adenocarcinoma. Classical picture of adenocarcinoma. So how will you investigate? You have to be extra careful. Radiology, very limited value in the diagnosis of GERD, but certainly helpful, for example, detecting strictures and large hiatal hernia in patient with dysphagia. Endoscopy is gold standard, useful for the diagnosis of esophagitis, hiatal hernia, gastric, duodenal ulcer, malignancy, and H. pylori infection. As I have already discussed, alarm symptom that in the presence of GERD immediately need endoscopy. For example, dysphagia, adenophagia, anorexia, weight loss, and GI bleed. So, approach to treat. There are different ways by which these goals can be achieved. The most important is lifestyle. Then comes the antacids and drugs. For example, in lifestyle modification, patient must avoid tight clothing around the waist, decrease dietary fat intake, lose weight, stop smoking, and need to raise the head end. So, muhtaat driving, महफूज सफर की जमानत. So, patient must not take मिर्च मसाला, गैस वाली बोतल, तली हुई अशिया, समोसे, पकौड़े, तिक्के कबाब, जो कि आजकल कॉमन है. ये चीजें he or she has to avoid. Otherwise, symptom will aggravate. Though they will not cause the symptom, but once patient is having either ulcer or GERD, patient need to modify his lifestyle. As far as drug therapy, as I have already discussed, that patient need to take over-counter NSAIDs, antacids, and sucralfate. Then the drugs, H2 antagonists, for example, cimetidine, ranitidine, famotidine, azatidine. There are different drugs, but you know that there are certain side effects related with these drugs, like cimetidine definitely has many side effects, and more or less, no, we rarely use this drug. Similarly, ranitidine last year, there are certain problems with ranitidine as well. Right now, we have only available with us is the famotidine. As far as proton pump inhibitors are concerned, they inhibit acid secreting enzyme, hydrogen potassium ATPase or proton pump, significantly more effective than H2 antagonist. Also more effective in severe cases of Gerd, and more are most effective in preventing recurrence. Then there are drugs like the first PPI that come into market was back in 89 and commercially 91 में launch हो गया था omeprazole, followed by pantoprazole, lansoprazole, and nowadays we have dexlansoprazole. H2 antagonist की बात करें तो 70% with reported relief within 2 weeks. So 70% patient within 2 weeks of treatment having a relief. There are 43 randomized controlled trials showed faster healing rate of patient with esophagitis compared with placebo. And sometimes higher dosage and twice daily dosage increases the efficacy. Once we compare these H2 antagonists with PPI in relieving symptom of Gerd, PPI are more effective. 12-week freedom from symptom, if you see, in PPI, 77% patient versus only 48%. 12-week healing rate, 84% versus 52%. And similarly, healing is more speedy. Once there are certain drugs that you need to give, like prokinetic drugs, and there are different groups of prokinetic like etopride, domperidone, levosulpiride. But remember, they have some role as alone, but PPI and prokinetic are more effective than prokinetic alone or PPI alone. So, how long do we treat? $1 million question. Nobody really knows. There are no firm guidelines. Most people will treat for 8 to 12 weeks and then have trial of medication. However, long-term management is needed, maybe in the form of intermittent treatment if patient is less than 60 years of age, absence of concomitant serious illness, no previous ulcer or complication, non-refractory ulcers, patient is not on NSAIDs, symptoms start gradually with each episode, not more than 2 relapse per annum. But patient may need continuous therapy if patient is an elderly one, coexisting medical condition like patient is suffering from rheumatoid arthritis or any other connective tissue order and need continuous NSAIDs intake or off and on NSAID. So these patients may need a continuous maintenance therapy. Previous ulcer complication, and for those who are continuing cigarette smoker, and for those having frequent relapse, 3 or more per annum, these patients need more or less continuous maintenance therapy, maybe low dose of PPI. So the people don't know their true power. You can see once you have a collective approach, you can treat a difficult task. But the NICE guideline on managing new dyspepsia, not caused by NSAIDs, patient is more than 55 years of age, having alarm symptoms. If yes, patient need GI endoscopy. If no, stop drug causing dyspepsia and lifestyle modification, over-the-counter drugs. stop drug causing, and once review after 4 weeks. If there is improvement, no further action. If there is no improvement, then need to test for H. pylori. And if H. pylori is positive, you need to give H. pylori eradication therapy that we will discuss shortly. If H. pylori test is negative, PPIR H2 antagonist for 4 weeks. If improvement, no further action. If no improvement, patient may need continuous therapy. After treatment for H. pylori, review after 4 weeks. If patient improve, no further action. If patient not improve, then again do urea breath test or stool for H. pylori antigen to detect whether eradication has been done or not. If again test is positive, do upper GI endoscopy. If test is negative, no further action is needed. So as far as gastric ulcer are concerned, stop NSAIDs if they are being used. Test for H. pylori, full dose PPI for at least 2 months in those where H. pylori is positive and ulcer is associated with NSAIDs. Eradication therapy should be given, and H. pylori के साथ आपने एंडोस्कोपी करनी है. Ulcer not healed, H. pylori negative, again you need to recheck. Test for H. pylori. If test for H. pylori is negative, full dose PPI for at least 1 to 2 months. And you can do endoscopy and again recheck is needed. As far as H. pylori eradication therapy, there are different regimens. The most common one is PPI in twice daily dosage along with amoxicillin 1 gram twice daily and clarithromycin 500 milligram twice daily for at least 10 to 14 days. There are other regimes in which PPI again twice daily. These are alternative regime, less commonly because where there is too much resistance with metronidazole, so you can use, but this is cheaper regimen where you can use PPI with metronidazole or clarithromycin. Alternative regimen, you can use azithromycin 500 milligram OD with dinidazole 1200 milligram OD and PPI. Then another regime is the quadruple therapy. PPI, bismuth, tetracycline, and metronidazole. This is the cheapest one, where for those patients who can't afford the clarithromycin as well as amoxicillin, where tetracycline OTC is quite cheap and easily available drug along with bismuth and PPI. Where active ulcer not attributable to H. pylori, then you can use PPIR H2 antagonist for at least 4 to 8 weeks and prokinetic for 6 to 8 weeks. Thank you very much. Questions are granted in live. But
thank you very much, sir. Excellent, बहुत जबरदस्त, very precise yet detailed presentation. और I hope कि बहुत सारी जो क्यूरीज होंगी लोगों के जहन में भी होंगी और बहुत सारी क्यूरीज सेटल हो भी चुकी होंगी. लेकिन before इससे कि we'll go for a question and answer session, I would request Professor Tariq Wasim Saab to have some expert opinion and some expert comments about this presentation. Professor Tariq Wasim Saab, can you please?
Thank you. Excellent presentation by my very dear colleague. And of course, there is hardly any place left for me to talk about. The main thing is that, I mean, it may be a question or maybe a comment as well. Khalid can respond to it. That among the available PPIs, right, we have to, I mean, of course, when you compare the efficacy of PPI with H2 antagonist and then, of course, simple antacids, you have a lot of choice. Some of the H2 antagonist, as he already mentioned, like this ranitidine, has been probably pulled out of market because of its some, say, untoward effects. Then we have this full range of this proton pump inhibitor, starting from omeprazole to lansoprazole to this pebeprazole and pantoprazole, and now we have dexlansoprazole. So do we have any, say, efficacy differences in these two? And of course, when talking specifically of dexlansoprazole, which was the reason we assembled today, any superiority over the conventionally available or already available PPIs. So, Khalid, can you put some light onto it?
There are certainly like जितने भी PPI है, एक तो उनके साथ था कि at least 1 hour before हमने देना है. So एक तो otherwise अगर हम efficacy wise देखें तो they are more or less same, but dosage they are bit different. You can use any, but the added advantage with this lansoprazole है, एक तो ये है कि इसका आपको meal के साथ कोई link नहीं है. You can give it before, after, or even with meal.
Right. I think this is probably the most important point to highlight. Yes. Because many times our patients
Similarly, for cardiac patient, those who are taking clopidogrel, उनके लिए भी certain there are कुछ PPI हम नहीं दे सकते, कुछ को हम दे सकते हैं. With dexlansoprazole, we can safely give.
Okay. I think Khalid has already responded to this. There are two, three, four things which we usually consider when prescribing a drug. One is as its bioavailability, and dexlansoprazole, as compared to the conventional esomeprazole or meprazole, has shown a better bioavailability and longer duration of action. Then is the efficacy. Efficacy is almost comparable whether you use lansoprazole. But the point which Dr. Khalid already highlighted was drug interactions and safety. The drug interactions, we do have limitation with the certain, particularly omeprazole and esomeprazole, particularly in cardiac patients. So this is one area. And I think there was some, I read somewhere possibly the dual mechanism of release of action as well, that this dexlansoprazole probably releases in 2 phases, if I'm not mistaken. And this would lead on to a longer duration of action. Anyway, coming back to the topic which was under discussion, GERD is taken sometime as very benign condition, but as highlighted by Professor Khalid Mahmud as well, that it is not to be taken as simply as a benign condition and just asserts the acid exposure to distal esophagus. It can lead on to complications in almost 5 to 7% of the patients, and these complications can be of serious nature as well. It may lead on to stricture formation. It may lead on to ulceration and the erosive esophagitis. It may lead on to a mucosal histopathological change leading on to Barrett's esophagus, and finally leading on to, say, development of adenocarcinomas as well. So anyone, and some then again in a particular age group, in those who have a risk factor of coronary artery disease, sometimes the symptoms mimic the coronary arteries, and with many a times patients they have to be say evaluated very thoroughly and very meticulously to rule out any coexisting coronary artery disease which may be masked because of the GERD symptoms. And the extent of investigations again depends upon symptoms and depend upon some warning signs. Anyone who has, as mentioned by Khalid, that who has any difficulty in swallowing or dysphagia or odynophagia, who has a weight loss, who is anemic, right, or who is having, having symptom duration of more than 6 weeks to 3 months, that must be scoped and that must undergo an endoscopy so that the serious nature can be diagnosed early. Rest, I think, has already been covered very nicely by Khalid, and I think if there are any questions from the audience, we can collectively take it up. Thank you.
Thank you very much, Dr. Sahab. Thank you very much.
Thank
It's been
you.
a pleasure. It's been a pleasure, and we are honored to have you with us.
I have a question, please.
Ji Altaf Sahab, we are listening.
Dr. Altaf Cheeman.
Yes, sir.
Professor. Thank you very much for this comprehensive coverage of the topic. अच्छा, मेरा question ये है कि this dexlansoprazole, it has been recommended initially for GERD only, and not because even if you look into the literature, they recommended for GERD. Is there any specific reason? Because it is a proton pump inhibitor initially, and why it is only recommended in GERD?
No, ये initial recommendation थी सर, अब ऐसी नहीं है. You can say.
क्योंकि initially तो यही बताया गया था हमें कि सिर्फ GERD में दे इसको.
था ऐसा नहीं, अब नहीं.
नहीं, मेरा ख्याल है कि मैं भी अभी 2-3 आर्टिकल इस पे देख रहा था, तो ज्यादातर it is recommended for all aspect of acid peptic disease, both the duodenal ulcer and of the gastric ulcer, as well as well, in fact, in treatment of even erosive gastritis, it has been now recommended.
Initial recommendation was
initially सिर्फ recommendation थी.
You are absolutely right. Initially it was, but right now no. अब ये सभी indication है.
Thank you.
Before taking some more questions, I would request हमारे पास एक और बड़ी eminent figure है लाहौर की Dr. Mohammad Aftab साहब, Associate Professor AMC. Sir, can you please share your feedback and can you please give us some expert comments so that हम उसके बाद आगे next questions पे जा सकें. Dr. Mohammad Aftab साहब.
Bismillahirrahmanirrahim. Excellent presentation by Dr. Khalid and followed by Dr. Professor Asim. So I think everything has been covered, and we should see questions from the audience so we can then conclude this session.
Okay, fair enough, sir. Good enough. Thank you very much for being with us. Now it's time for question and answer session. We have expert with us. We have some heavyweights with us. So anybody have any question, you can please ask from Professor Tariq Wasim Saab and Professor Khalid Mahmud Saab and
Dr. Furam want to say something. Dr. Furam.
Ji Dr. Saab, please. Dr. Furam, please.
Dr. Furam raised hand.
Yes, so many hand raised. So,
Dr. Furam, do you want to ask something? Dr. Furam को kindly unmute कीजिएगा.
Dr. Furam आप खुद unmute कर सकते हैं.
नहीं, उधर से ही होगा, नहीं होगा. चले, तब तक अगर किसी और पार्टिसिपेंट का कोई क्वेश्चन है तो प्लीज आप पूछिए. तब तक डॉक्टर खुरम भी अपने माइक को अनम्यूट कर लेंगे तो उनका भी हम क्वेश्चन ले लेंगे. एनी क्वेश्चन फ्रॉम एनी पार्टिसिपेंट प्लीज.
सर क्वेश्चन ये है. अस्सलाम वालेकुम. मैं डॉक्टर साहब हूं. अच्छा सर, ये बताइएगा कि अगर ये सार रेज एक्सप्लोरी टू भी देने के बाद जब स्किन पॉजिटिव रहते हैं देन क्या ट्रीटमेंट होनी चाहिए?
सॉरी, आपकी आवाज क्लियर नहीं आ रही.
आप अपना क्वेश्चन दोबारा पूछिएगा काइंडली.
अस्सलाम वालेकुम.
वालेकुम सलाम.
आई एम डॉक्टर नईम. मैं पूछना चाहता था प्रोफेसर से कि यूजुअली जो ये हार्ट डिजीज चेस्ट पेन जो है, जो हार्ट बन जाए, दिस इज सम टाइम कंफ्यूज्ड विद द हार्ट अटैक. तो इट इज वेरी डिफिकल्ट टू डिफरेंशिएट इट फ्रॉम हार्ट अटैक. अगर इस बारे में कुछ रहनुमाई फरमाएं तो शुक्रिया और बहुत मेहरबानी होगी.
जी, इस पे थोड़ी सी मैं बात करूंगा, फिर मैं तारिक साहब से, क्योंकि जिनका कार्डियोलॉजी में बहुत ही एक्सपीरियंस है. एक तो ये है कि जो एसिड पेप्टिक डिसऑर्डर्स हैं, दे आर मोर और लेस रिलेटेड विद फूड. जैसे मैंने बीच में लेक्चर के दौरान भी बात की कि जो गैस्ट्रिक है प्रॉब्लम, वो एग्रीवेटेड आर रिलीव्ड बाय टेकिंग फूड. ऑन द अदर हैंड, ischemic heart disease usually aggravated by exercise or stress. Though there are certain gastric condition भी ऐसी होती हैं कि वो कई दफा मिमिक करती हैं, but more or less अगर चलने से चेस्ट पेन होती है या एपिगैस्ट्रिक पेन है और पेशेंट की एज above 50 है, so I personally think so कि even इवन पेशेंट नहीं भी कहता कि जी चलने से और अबव 50 है तो उसकी ईसीजी करके रूल आउट कर लेनी चाहिए। जी सर।
Right. I can respond to this question. I mean, when you are talking of patients suspected of cornea disease, the first thing हम ये कहते हैं global assessment के atherosclerotic cardiovascular disease risk score. So those patients who have a high atherosclerotic cardiovascular disease risk score, which includes taking into consideration risk factors like age, hypertension, dyslipidemia, family history. So if they are high, so they should be suspected of coronary artery disease before labeling them as GERD. Character of pain, Dr. Khalid ne already highlight kar diya, but pain which is more of a burning in nature or acid with the reflux with related to meal, postprandial, worsen on lying down, probably favors say reflux, right? But in particular, I would like to highlight one more thing. There's a term called postprandial angina. That's a very well recognized term. Many patients complain of a inguinal pain of ischemic origin after taking meals, particularly when they take meal and walk. The theory behind that is that when you are having a critical narrowing of the coronary vessels and the blood supply to the myocardium is limited, and when you take a meal, most of the circulation is diverted to stomach and splanchnic circulation to say absorb that, and you may have a relative ischemia of the myocardium presenting as postprandial angina. So this is again would be more likely to be considered in patients who are have high cardiovascular disease risk scores. So Khalid very rightly mentioned anyone 45 or 50 plus and with more than 2 cardiovascular risk factors should first be ruled out of having an ischemic heart disease, because GERD से बंदा फौरी नहीं मरेगा. Ischemic heart disease, myocardial infarction फौरन मरेगा, and we have had some very say of course accidents among our own community. We have lost 2 of our friends who keep on referring to their pain as a gastritis or gastritis and ended up with, unfortunately, with an acute severe myocardial infarction. And I mean, I would not, refrain from mentioning Professor Harun Rashid was the example of that he had symptoms and he was probably told to consult cardiologist, and he keep on referring, and finally, unfortunately, had a severe catastrophe. So, Dr. Naim, your question was very well taken, and of course, I hope that we would like to rule out, possible ischemic heart disease by taking such precautions and taking a careful history as well. Thank you.
Thank you, Dr. Naim, for your question. I hope this answers your question. Participant में से अगर कोई और को question करना चाहते हैं तो we have expert with us, Professor Khalid Mahmud, Professor Tariq Wasim, and Dr. Mohammad Aftab. This is an opportunity.
Yes, yes.
जी डॉक्टर इरफान, आप कुछ पूछना चाह रहे हैं?
हेलो, अस्सलाम
वालेकुम अस्सलाम।
सर हेलो,
काइंडली अपना इंट्रोडक्शन करवा के सवाल पूछिए आप।
डॉक्टर सरफराज है जी, डॉक्टर सरफराज लाहौर से। अच्छा सर, मेरा क्वेश्चन ये है कि हेलो
जी, आपकी आवाज आ रही है, आप पूछिए।
अच्छा सर, मेरा क्वेश्चन ये है कि क्या हमें ESR को भी कंसिडरेशन करना पड़ेगा कि अगर एज करोड़ी 2 वीक या पोस्ट कराने के बाद PPI, मैकोलाइट ग्रुप और अमोक्सिसिलिन, मेट्रोनिडाजोल देने के बावजूद अगर एच करोड़ी पॉजिटिव रहता है, then what should we do right now?
Right. I can respond by saying that H. pylori is quite difficult to eradicate. It can recur again and again, and we do come across this problem. But as you said, that ESR as an indicator of ongoing H. pylori infection, that probably is not true, because the inflammation it does reside in the antrum and may lead on to some changes, but not into the extent that there is a severe inflammatory response that an ESR can be indicator of that infection has been eradicated or not. Now, the best test to check for eradication would be probably either checking for the stool antigen, right? And so you to check for the H. pylori stool antigen non-invasive test. Otherwise, Khalid mentioned that you had either to go for an endoscopy and take a biopsy or urea breath test, or H. pylori antibodies are again not very specific. This is IgG and IgM, and sometimes IgG remains positive for quite some time. And even if so what I think is that you have to go by symptoms, and if you still want to say that it will be possibly eradicated, Khalid can comment it on. I think the negativity of a stool culture would be a more appropriate test to look for that whether you have eradicated. And then minded that reinfection is also very common. Khalid, you can respond to it.
Ji. As far as H. pylori is concerned, sir, you rightly said ESR has nothing to do with this. लेकिन दो चीजें इसमें बड़ी जरूरी हैं कि जो H. pylori के लिए हम टेस्टिंग है, there are invasive and non-invasive टेस्ट. अब नॉन इन्वेसिव में फॉर द फर्स्ट टाइम तो आप ब्लड में कर सकते हैं एंटी एच पाइलोरी, जो IgA या IgM जो एक्यूट इन्फेक्शन को शो करता है, एंड IgG फॉर क्रॉनिक इन्फेक्शन. अब रिमेंबर ये एक कॉमन प्रॉब्लम है. फॉर एग्जांपल जैसे हेपेटाइटिस सी में था, एंटी HCV हम हर एक का करवाते जा रहे थे, वो IgG एंटीबॉडीज है वो पॉजिटिव रहनी है. सिमिलरली डेंगू में आपने देखते थे एंटी डेंगू एंटीबॉडीज, वो भी IgG फॉर लाइफ कई दफा रहती हैं, अनटिल अनलेस इम्यूनिटी कम हो या कोई और रीजन हो तो वो कम होती हैं. सो फर्स्ट टाइम तो आप कर सकते हैं कि आपने एंटीबॉडीज के उस पेशेंट को आपने ट्रीटमेंट नहीं दी हुई, बट फॉर फॉलो अप एंटीबॉडीज हैज नथिंग टू डू. उसके लिए फिर आपके लिए अगेन आप दो तरह से कर सकते हैं. इन्वेसिव में क्लो टेस्ट है, कंपाइलोबैक्टर लाइक ऑर्गेनिज्म है जिसमें आप बायोप्सी लेते हैं, यूरिएज उसमें प्रोड्यूसिंग ऑर्गेनिज्म है, एंड यू कैन देयर एंड देन टेस्ट कि वेदर उसमें H. pylori है या नहीं है. या फिर हम स्टूल फॉर H. pylori एंटीजन और यूरिया ब्लड टेस्ट, ये हमारे पास 3 कॉमनली अवेलेबल टेस्ट है. अगर ये पॉजिटिव है तो रीट्रीट भी. लेकिन एक चीज याद रहे कि H. pylori जो है वो ओरोफिकल रूट से होता है. अगर आपकी हाइजीन अच्छी नहीं है, आपका ईटिंग स्टाइल अच्छा नहीं है, तो आप भूल जाएं कि ये खत्म होगा. क्योंकि सोचते तो वही है आपने कि अगर हमारा जो ईटिंग स्टाइल है कि हम जहां से बैठे हैं प्लेटें भी साफ नहीं है, जहां पे दिल किया वहीं से खाना खा रहे हैं, ग्लास धुले हुए नहीं है, उन्हीं में खा पी रहे हैं, तो जो ओरोफिकल रूट से जैसे इंटेरिक फीवर है, जैसे इन्फेक्शियस हेपेटाइटिस है A और E, इसी तरह H. pylori जो है ये भी प्रॉब्लम है. सो क्योंकि आपने ट्रीटमेंट तो कर दिया तो वो उस वक्त तो इन्फेक्शन ठीक हो जाएगी, तो इसकी जो एंटीबॉडीज है वो प्रोटेक्टिव नहीं है. ये इंपॉर्टेंट याद रखने की बात है कि आपने एक दफा ट्रीट कर लिया, उसके बाद अगर आपने अपना लाइफस्टाइल चेंज नहीं किया तो दोबारा हो सकता है. उसके लिए बेस्ट है कि एक तो पानी उबाल के लें,